Our next speaker is Vishal Janji, who's going to talk about crosslinking, achieving maximum effect for keratoconus.
Thank you, Sanjay. So the only disclosure that I have is that I'm going to talk a lot about Kmax. And I'm already scared, Michael. All right, we all know keratoconus is characterized by axial or paracentral stromal corneal thinning and progressive irregular astigmatism. Normal cornea is made up of parallel collagen fibers, and now we know that in keratoconus there's a reduction in the number of these collagen fibers, degradation and displacement of these fibers, and also rearrangement. All the traditional techniques of management of disease, they just improve the vision, but they do not alter the course of the disease. And so here comes the role of corneal collagen crosslinking, which was approved by the FDA in April 2016 to treat patients with progressive keratoconus and post-LASIK ectasia. Typically a day procedure, unless you work in a university-affiliated pediatric hospital. We take off the epithelium, soak the cornea for 30 minutes in riboflavin, and then irradiate with UV light for another 30 minutes, typically done under topical anesthesia. So how do we measure the effect? Well, traditionally, the primary outcomes are measuring the Kmax, uncorrected visual acuity, best spectacle or contact lenses, corrected visual acuity, and the secondary outcomes are basically related to the visual acuity again. You look at the SEQ and cylindrical correction in these cases. One of the nicely done randomized controlled trials from Melbourne, this slide presents the 3-year outcomes. You can see a significant reduction in Kmax at the end of 3 years with the Treston protocol, and also an improvement in uncorrected visual acuity as compared to the controls. And if you look at the literature, most of the studies that followed that randomized controlled trial, including the one in the United States, they've shown variable decrease in Kmax and a modest improvement in UCVA and BCVA, ranging from nothing to about 2 lines after cross-linking. Variations have been introduced, mostly outside of the United States. In addition to conventional cross-linking, we are looking at transepithelial cross-linking now, where we don't take off the epithelium to reduce pain and risk of infection. We can use hypoosmolar riboflavin in thin corneas. You can also save time by using high fluence or accelerated cross-linking, and you can combine these procedures, cross-linking with refractive procedures, mostly surface ablation. In general, the predictors of success, high K values, and I'll discuss more about that, young age, typically between 18 and 39 years, and a central cone. So let's talk a bit about the Kmax. A single study suggested in 2009 that if the K values are more than 58, it's going to fail. But if you look at the literature, all subsequent studies have shown otherwise. If you start with a high K, even if it's more than 60, you're going to have a lot of flattening, and that improves the visual acuity as well. We actually found that the topographic response is differential depending on where you start. And typically, if the K values are more than 58 diopters, you will see a very good response to cross-linking. This is a young patient. This is a swept source OCT. You can see at the end of 1 year, there's a reduction in steep K values from 50.4 to 49.5, so approximately a 1 diopter reduction. Another patient where we started with 59.1 diopters, so nearly 60 diopters, and at the end of 1 year, you have a 4 diopter flattening on the steep K values. It's down to 55.1. Another young patient, if you focus on the central K values, they're down from 70 at the end of 1 year to about 64.8, and this was associated with a significant improvement in uncorrected and best corrected visual acuity. Another way to modify cross-linking is to sort of speed it up. The concept is to deliver same amount of energy by using different iterations. You can use the UV light for 30 minutes or 5 minutes or even for 3 minutes. So again, the overall concept is to increase the patient comfort, increase the productivity of your OR, reduce corneal thinning during the cross-linking process, and possibly reduce the incidence of post-op corneal haze and pain. Lab studies mostly have shown that if you perform high fluence cross-linking, the change in Young's modulus is not as great as you see after traditional cross-linking. And it has been shown that once the efficacy of cross-linking decreases as you increase the UV light from 3 to 18. Clinically, we did not find a significant difference between conventional and accelerated cross-linking in terms of the change that they induce in Kmax values. But if you look at these values, the change introduced during conventional cross-linking was 1.6 diopters. That is Kmax. And if you look at the high fluence numbers, that's only half a diopter. So majority of the studies, they found that high fluence cross-linking is inferior to Dresden protocol as far as flattening of cornea is concerned, although the procedure is found to be very safe. The demarcation line, which is a surrogate marker for efficacy of cross-linking, was also shallower in high fluence as compared to conventional cross-linking. Transepithelial cross-linking, as I mentioned earlier, it's supposed to be less painful. The visual recovery is quicker. Your patients will still need a bandage contact lens probably for a day or so. Less risk of keratitis. Obviously, the bigger issue is penetration of riboflavin, and researchers around the world have used different materials, different eye drops to increase the penetration of riboflavin into the cornea. Because we know the other issue is that epithelium will sort of retard or lessen the absorption of riboflavin and also the UV light through an intact epithelium. Again, animal studies have shown that increase in corneal rigidity is different when you leave the epithelium on. It equates to roughly a lesser level in human beings. So it's 21% versus 102. That's epi on versus epi off. Equates to 64% versus 320% if you look at human eyes. But we really don't know whether that is enough for clinical effect. Histological evidence also suggests that the treatment is less deep if you do a transepithelial cross-linking. If you look at the clinical studies, mostly outside of the United States, the results are variable with transepithelial cross-linking. Doyle-Stulting's study published in 2018, they used pulse cross-linking with pulse oxygen, and they actually showed that there is a decrease in about half a diopter in Kmax values in transepithelial cross-linking. Strangely, if you do transepithelial cross-linking in steep corneas, in very steep corneas, more than 58 diopters, you still see a good decrease in Kmax values. Briefly on post-LASIK ectasia, I know Maria is going to take it up. These cases, they typically present, they're very steep. The cone is usually inferior, not a central cone. You can lift the flap if you want to increase the penetration of riboflavin, or you can do cross-linking over the flap. This is a patient with 57 years old, 3 months follow-up, and you actually see the cone is mainly inferior. The K values are down from 56.8 to 54.3. So that works as well. So to conclude, conventional cross-linking has a greater flattening effect as compared to other protocols. Steep corneas, they tend to flatten more as compared to flatter corneas. Cross-linking works well for inferior cones and post-LASIK ectasias, and protocols continue to be modified to achieve better efficacies, mainly customized cross-linking to actually focus on the cone. You can also use iontophoresis in transepithelial cross-linking, and of course, I'm sure everyone in the US is now excited about pulse cross-linking and transepithelial cross-linking. Thank you very much for your attention.